Good morning, everyone. We are about to begin. We're sorry we are just a couple of minutes later. One of our presenters is on her way. She's not here yet, but we will, in the interest of time, to make sure that you get maximum information out of our distinguished plenary speakers, we will begin. So welcome, I should say officially, welcome to the second day for our National Conference for Health and Public Housing. We hope that you have been enjoying the session so far. Yesterday, have we been enjoying the session so far? All right, wonderful. So yesterday we had the honor of having some really wonderful speakers, Dr. Marsha Brand, Captain Henry Lopez, Congresswoman Donna Edwards, and Dr. Jim Hunt. Well, today we have just as wonderful a lineup of plenary speakers for you today. So we're really enthusiastic and excited about the information they're going to share with you as grantees. We have had some wonderful workshops yesterday. We will continue doing those today to provide you that training and technical assistance that you need. I do want to make one or two, three announcements. First of all, I want to remind you that our vendors and sponsors were part of this year's success. So we really want to encourage you to visit with them. A couple of them have programs and services that can help you, and some of them are actually attached to some revenue streams potentially for your health centers. So please stop by and speak to them as well. The work that you're doing is so important, and we are going to link every type of resource that you can leverage in order to make sure that you remain successful and continue to provide affordable access to quality care for residents in public housing. So please take advantage of that as well. For those of you who are members of this year's Clinical Quality Working Group and Strategic Plan Committee, at 12 o'clock, we have a meeting in the boardroom. So you already know who you are, so please head to the boardroom at 12 o'clock. We must end promptly at 1 so that you can all get to your sessions as scheduled. And then today lunch is on your own, so we hope that if you're planning to eat here in the hotel that you considered making your reservations, as there are going to be a lot of requests today. We want to make sure that you're able to eat during that hour session and before today's workshop session. So I know it's raining a little bit outside there, but there are a couple of areas in the walk, just outside as well. Alexandria is a healthy, walk-friendly community, so we really ask you to take advantage of that as well. Okay, so I don't think we have any more announcements at this time, and I am really, really honored to have our plenary speakers again this morning. They're all distinguished, and after they share what they have with you, you'll understand that as well. Do want to recognize our HRSA project officers, Captain Henry Lopez, HRSA leadership. They are the ones who support this corporate agreement to provide this training and technical assistance for you. So again, thank you. And the NAM staff, I do every day. I have to thank them for their hard work and efforts. So I'm going to turn it over to this morning's moderator, and this is Ms. Zara Marcellian, who is the CEO of La Maestra, one of our proud awardee recipients again for the H. Jack Geiger Award. So I'm now going to turn over this morning's session to her. Thank you.
Thank you very much, Dr. Webb. This is quite an honor. This is the first time I've served as moderator, so your patience, please. Of course, I could stand up here all day and talk about the health center, but I know I'm not going to do that. Yeah, okay. Well, our first speaker is Kathleen O'Leary. Kathleen O'Leary is Deputy Chief of Women's Program of the National Institute of Mental Health, and she leads the women's team of scientists which reviews and administers grants on women's mental health research at the National Institutes of Health. Her work involves studying adolescent mothers and their infants, borderline personality disorders, and she's the supervisor of staff working with patients with schizophrenia, and as a supervisor of the patient screening and human subjects protections team. Her journal publications include studies on adolescent pregnancy and depression and book chapters on neuropsychological testing in personality disordered patients. She works closely with the NIH Office of Research on Women's Health, as well as the Department of Health and Human Services Office on Women's Health initiatives that include perinatal mental health, sex differences research, health disparities, the mental health issues of women serving in the military, and the mental health effects of violence. So here we're going to welcome Ms. Kathleen O'Leary. Thank you.
No, that's not it. There we go. Thank you. It's a pleasure to be here. And I appreciate the invitation from Dr. Webb. I usually address mental health researchers and practitioners, so this is a really very lovely change of pace for me. I'm going to give you a quick overview about some mental health issues in general and for women in particular. And I hope that you come away with a clearer idea of why this all matters. So a quick background, I work for the National Institute of Mental Health, which is one of the 27 NIH institutes and centers. And we fund neuroscience research. Our mission, you can read up there, is pretty straightforward. So we actually focus on funding the research. Other agencies such as HRSA and SAMHSA focus more on the implementation of evidence-based practice. We actually try to discover and publish information about the evidence-based practices. And other agencies, we do some training of healthcare practitioners, mostly of researchers, and the other agencies, HRSA and SAMHSA, actually do more of the training. Sorry, I just lost my place. And I'm focusing today on women's mental health because that's the area in which I am currently working and what I know best at the moment. There is no artificial barrier between the body and the brain. Mental health and mental illness have systemic effects. So that's why we say there's no health without mental health. And we're focusing on women because women are generally the gatekeepers for the family's health. They make most of the healthcare decisions in a family. Women usually care for an ill family member and make those decisions. Maternal health strongly affects the developing child's health, which there's been much research about this. And pregnancy provides an opportunity for clinics and healthcare practitioners to have an entree into a family and provide guidance to women and families. So how common are mental disorders? They are really common. This is a 1 year, this slide shows 2008, 1 year, more than 4% of Americans in any given year have a serious mental illness. And it's actually estimated that close to 1/3 of Americans in their lifetime will experience a diagnosable mental illness, most of which are not treated. Women are more likely to get certain disorders, and women are more likely to get mental health disorders in general. They are common, they are debilitating, and they are often chronic. Now, this slide is from the WHO, World Health Organization, and at the WHO, they tend to focus on the burden of disease, which means number of years lost to disability or death. So this actually is all about women. The lighter line is low and middle income countries, and the darker line are developed countries. And you can see at the very top of the list of disease burden are unipolar depressive disorders, in other words, major depression. And this causes more disability and health burden than HIV/AIDS, than tuberculosis. And as a matter of fact, I don't know how well this is publicized, but depression is the leading cause of disability worldwide. Besides causing disability, mental health disorders also can lead to death. As we well know, suicide rates are not dropping in this country. And the mental disorder with the highest mortality is eating disorders. So returning to this slide again, we could easily spend an hour on the current research that seeks to understand why there are differences between the sexes in the occurrence of mental disorders and among the races. As you can see on the slide, African Americans actually have lower rates of serious mental illness, as do Asians, and these are all in this country. And whites and people of mixed race have highs. Now, these are averages again. These are huge epidemiological studies, so this may or may not pertain to any individual. But today we're really looking at women and sex differences. Now, sex differences that I'm talking about may not be quite as lively as sex differences in other arenas, but they're important to know about. And you can see, I think I need to walk around to do this. I don't know if it's going to reach. Anyway, the line, the bluish-grayish line, if a disorder meets the line, it means it's a 1-to-1 ratio between women and men. If it's above the line, it's greater in women. If it's below the line, it's greater than in men. And you can see, like the first and the third disorders, schizophrenia and bipolar illness, equal distribution among women and men. If you look at depression, it is almost twice as common in women as in men. If you look further along the line, the one that's sort of the fifth one, I believe, that is PTSD, which is almost 5 times as frequently occurring in women as in men. The very tallest one is anorexia, which is not surprising that we know it's higher in women than in men, although it is increasing in men. And the disorders that are more common in men are attention deficit hyperactivity, drug and alcohol dependence, and antisocial personality disorder. So although we often talk a lot about depression because it's sort of better understood and more well known, the most frequently occurring mental disorders in the United States are anxiety disorders. And again, these are the most recent huge epidemiological studies. So anxiety disorders include generalized anxiety, post-traumatic stress disorder, PTSD, social phobia, obsessive-compulsive disorder, and other disorders. And PTSD is very interesting in terms of women because men are more likely to experience a trauma in their lifetimes. But women, when traumatized, are more likely to develop PTSD. And researchers are devoting a lot of time and effort to examining why this is true. As a social worker, I try to bring neuroscience kind of down to a comprehensible level. And I can tell you that the male and female brains are wired differently. Neural circuits in the brain, when they are exposed to fear and anxiety, operate differently in men and women. And all of this is mediated by hormones in terms of development of these disorders. Also, some very recent findings within the last year have shown that some women have a greater genetic risk. We're actually doing a lot of supporting research on the genetics of these disorders. There's also the nature of the trauma itself, and there are theorists who believe, and researchers who believe, that because women are more likely to be exposed to sexual trauma, either as children or as adults, that resonates differently, physically as well as emotionally, and can lead to higher risk for subsequent disorders developing when traumatized again. For instance, if a woman has had childhood sexual abuse, enters the military, is exposed to combat, she is probably more likely to develop PTSD than a male soldier. So, as I was saying, biology matters in terms of the differences as we try to understand the development in the course of mental disorders. Biology matters, social experience matters, and the environment matters. We don't know a lot about neurotoxins and exposure to neurotoxins and how they affect brain functioning and health in general, as well as mental health. We do know that poverty is an environmental factor, and living in poverty is an environmental factor that leads to greater disease. And we do know that chronic stress leads to greater disease. This has all been very well studied. And there's research, actually breast cancer research, that shows that living in a dangerous neighborhood and feeling isolated increased risk for breast cancer among urban women. And this is controlling from the accessibility to care. So these two issues separately, these two factors separately, can lead to a worse health outcome. It's also the highest rates of postpartum depression have been found in an urban, low-income African-American group of women. More information about why women are more at risk. Women are the orangey line and men are the blue. If you look along from the bottom, boys and girls equally likely to develop depression. Then all of a sudden, puberty hits. The female rate goes up dramatically and stays up for most of a lifetime. You can see kind of another jump upwards probably around the time of perimenopause or postmenopause. And this slide doesn't show it because it ends at 54, but the two lines actually converge among seniors, and a male and female. Actually, unfortunately, depression goes up in males and it goes down in females, unfortunately for the males. Good for the women, but. So I put this slide in here because some of you may know about the Army STARS study. It is a very high-powered, unique study, collaboration between the U.S. Army and the National Institute of Mental Health, trying to quickly determine what are the causes of some of the really mental health crises in our active duty military and our deployed soldiers and our returning veterans, and what can be done about it quickly to identify those at risk. So again, something we could talk about all day. You can really look it up, Army STARS, STARRS. It's about risk and resilience. And an important thing in terms of women, which is what I'm focusing on today, is that there are still not enough women serving in the active duty military to be sort of statistically viable, and certainly, and even a smaller proportion serving in combat. However, women are being oversampled in the study so that we will end up with very useful information about what leads to depression and PTSD and the causative factors and the correlations for women in the military in particular. As I mentioned, SAMHSA, which is Substance Abuse Mental Health Services Agency, does more of the implementation of healthcare along with HRSA and other agencies. So one of the things is that I really appreciate about SAMHSA is they are focusing on trauma-informed care. They are training practitioners, they are publicizing it, and I can't overestimate how important this is in terms of healthcare. Somewhere on their website you can find the slides that there's a really massive children's study that's been done, and a progressive study that shows that exposure to trauma as a child leads to higher rates of tobacco, higher alcohol and drug abuse, a higher rate of homelessness, and it's really pretty easy to ask as a clinician, have you experienced something terrible or something frightening in your life? And to find out that, and answers to that can determine a higher risk for all kinds of health disorders. So as I've said, brain disorders affect more than the brain. These are clippings from a number of different sources that show maternal distress raises the risk of childhood asthma, depressed moms, kids are at higher risk of injury. Actually, children of depressed moms are at higher risk for a lot of things. And it's not just moms who are depressed, it's moms who have anxiety disorders too, and men are now being studied. And so obviously the paternal influence matters also, but the early childhood environment provided by parents is very important, as you all know, better than I do, I'm sure. Depression is linked to bone loss in young women. Here's a recent press release from SAMHSA that basically says adults who have mental illness, and remember, if it's 1 out of 3 in a lifetime, this is someone in your family. These are people that you know and who are probably, it may be undetected and untreated, but you are living among people who have mental illnesses. So if you have mental illness, you're more likely to have high blood pressure, asthma, diabetes, heart disease, and stroke. And research has also shown that health outcomes are better if the mental disorder is treated, and utilization of other health care declines if mental health is treated. This is an older slide. It always shocks me every time I see it, though, because it's about death rate. And in the months after a heart attack, comparing people with depression, the green line, people without depression. So it's pretty dramatic. I mentioned the links between depression and osteoporosis in women. There's a graphic illustration. Again, this has been known in science for quite some time. Services. Services are a compelling issue in which you are all about today, and you are more the experts in this than I am. But although we need more trained mental health practitioners, it's really clear that screening for mental disorders is going to have to take place also in primary care settings. And hopefully, when the Affordable Care Act is fully implemented in their medical homes, that is going to help in that effort. So patients are resistant to seeing mental health professionals, as you probably well know, or people will be getting more treatment, most likely. And practitioners are often hesitant, non-mental health practitioners are hesitant to screen because if you don't know who to refer to, you don't want to ask the question. And this is really the sticky issue, I think, in mental health services today. The screening can only be effective if there are referral routes within a healthcare system and within a community. And much more work needs to be done in this. We're doing research on efforts to engage women and men in treatment, capacity building, access to care. You all know that the type of healthcare system and who pays the bills is the key to service delivery. You might notice that I haven't really mentioned the need for more treatment research at this point. And certainly we need better treatments. But we have treatments that work. We absolutely have treatments that work in mental health. We have cognitive behavioral therapy for depression, for anxiety disorders. It's been shown over and over that it works. It's talk therapy. It's called CBT. It's very effective. We have medications that are effective. Sometimes someone has to try more than one medication to find out what the best medication is, but medications and therapy together work great, or either of them works by themselves. So we have the treatments. The key for mental health is getting people into treatment. And people don't have to start with an MD. Social workers provide the majority of outpatient mental health in this country. Ministers, pastoral counselors are very good at providing counseling and an entree into mental health. Nurses, there are all kinds of people out there providing mental health counseling, or whatever they call it. And clinicians in primary care can also ask some simple questions like, have you had a change in your mood or behavior in the last couple of months? Do you find yourself worried more so that it interferes with your life? Are you concerned about any member of your family that has issues around these? So some of it is openness to asking the questions as well as having a referral route. I mentioned a couple minutes ago, pregnancy provides an entree into family health care. We spend a lot of time in our office focusing on postpartum mental health. We say perinatal because we know that most postpartum depression begins during pregnancy. And we're funding a lot of research on depression and anxiety. We have a great video on our website. A very brave young woman who's participated in research and has spoken very movingly of her experience with postpartum depression and how it affected her parenting and how she's better now. This is actually a HRSA brochure that we have linked to on our website. HRSA does a lot of screening for postpartum depression in their Healthy Start centers. HRSA also screens for domestic violence. And For years, we've been taught that the greatest risk factor for postpartum depression is a previous history of depression. New research shows the greatest risk factor for postpartum depression is recent history of domestic violence. So it's important to know. And this has not sort of spread, this awareness has not spread into the mental health or the health communities yet, I don't think. Okay, resources. They're really all on the web. If you scroll down below all of this, so it's nih.nih.gov. If you scroll down, you'll come to all of our videos. We have a lot of videos. They're on YouTube. You have to hit more a couple of times to get to the postpartum depression one that I mentioned. SAMHSA, again, focuses more on the provision of services. They have an effective practices database that you can get to from here, and they also have a therapist locator that we link to from our site, and hers also links to from their site. It's not perfect, but it's a beginning. And I just put this, womenshealth.gov, also a great resource for women's health and women's mental health. That's really our umbrella mother agency. And thank you very much. There is my contact if you needed to email me for anything. If we don't have time for questions, we'll see. o'learyk@mail.nih.gov. Thank you.
Thank you so much, Kathleen. I think these studies are absolutely imperative for us that are at the community-based level in trying to develop innovative programs for our diverse cultures that are so, affected like everybody else with mental health issues. Now our next speaker is Marcia Thomas Brown. Ms. Marcia Thomas Brown has an extensive and accomplished experience in healthcare operations, spanning major segments of the healthcare continuum, including long-term care, acute care, outpatient, and rehabilitative services, managed care with a focus on chronic disease management and prevention, community education and outreach, and business development. Currently, Ms. Thomas Brown serves as the Chief Operating Officer for the National Health IT Collaborative for the Underserved, and she is a graduate of George Washington University. She holds a master's in Health Services Administration and Wharton School of Business, Leonard Davis Institute of Health Economics Executive Leadership Training Program, University of Pennsylvania. In addition, she is a licensed nursing home administrator and a certified medical technologist. So we welcome Marcia Thomas Brown. Thank you.
Thank you. Good morning. Good morning. Good morning. All right. How many providers we have in the audience today? Staff supporting physician practice? Okay. I was asked to talk about the implementation of electronic health records and to be able to give you some information about why providers need to do this. And that there are very specific reasons why providers need to do this. But my approach today, after being in the field for 2 years, is to be more focused on boots on the ground, is what we call it, action-oriented, and give you a specific example of what we're doing out there, we meaning the Office of the National Coordinator, the Office of Minority Health, and NHIT, what we're doing out there to support providers in underserved communities to adopt EHR. The approach that we took in this particular case is trying to meet the challenge, the financial challenge that providers have in adopting EHR. The incentive is there if you're able to adopt EHR and reach meaningful use. And so our approach was to try to help providers get to that point. One of the things that we found out is that the adoption of EHR in all communities, but specifically in underserved communities, is a process. It is, for the most part, a lengthy process. It's a process that must contain trust within those participating in the adoption. It must be a process that is consistent in terms of what you are doing and how you are doing it. It's a process that must be flexible. There is not one practice that is equal to another practice, even though they might be, owned by the same person, the same organization. And so today, I can always reference the specifics as to why you should adopt, but I'm here today to let you know that we understand the difficulties in adopting and that there are resources out there that can help you adopt. So with that in mind, here we go. The National Health IT Collaborative for the Underserved began in 2008 when a group of leaders from Summit Health Institute for Research and Education and other partners realized that the whole issue of implementing NHIT was a wonderful endeavor. However, after attending a HIMSS meeting, they also realized that underserved communities and communities of color were not at the table when this process was taking place. And so they decided that they needed an organization that would be able to work closely with underserved communities to ensure that they benefit from health information technology as a whole, not just EHR, but health information technology. And this is where NHIT was founded. And again, our focus is primarily to empower consumers to use technology to better manage their health. We promote HIT adoption by providers in underserved communities. We spend a whole lot of our time doing that over the past 3 years. Foster creation of HIT workforce, and facilitate funding for HIT implementation, which is what we're going to talk about. Also, we work very closely with all the federal agencies, the private sector, advocates, stakeholders, everyone, because as a collaborative, that's exactly what we do. We bring everyone to the table and collaborate to try to resolve the problem. So I'm glad to see that HRSA is here because that's one of our favorite agencies that support the collaborative and our work in the field. As I said, when this started in terms of EHR adoption, their letter went out from then the head of ONC, Dr. Blumenthal, and the head of OMH, Dr. Garth Grant. They're no longer with us, but they started this process. And pretty much what they said was the federal government had invested billions of dollars in implementing this process. The process of adopting EHR, the process of supporting providers, primary care providers, in reaching meaningful use and be able to collect incentive dollars so that they can continue this process. However, they realized that was not enough. We needed more resources to be able to get this done, to bring 100,000 providers to adopt EHR by the end of 2014. This letter went out to the vendors and pretty much said, we need help. we're here to show you how you can benefit from a return on investment in underserved communities. And we want to talk to you and be creative as to how you can help us. Now, that was then. 2010 is 2012. I just did a presentation with Dr. Hunt, the head of ONC Provider Adoption Program. This is actually his slide. And, the good news is that we're moving forward. The bad news is that we're not moving forward at the rate that we should. And so when you look at the primary care provider adoption, 2010, 30%, whoopee. Small practice, less than 10 providers, which is where our focus is, we're looking at about 21% at this point in time. Now, that's one of the issues that we have in terms of exactly how many providers in underserved communities have adopted. And I'm pleased to say that after talking to Dr. Hunt, that actual information will be released shortly. They have been doing some research and doing some surveys, and so very shortly we'll be able to know exactly where we stand as it relates to providers in underserved community. That information is coming. But the bottom line is that what's going to happen is that it will give us more specific information geographically as to what the issues are, but we already know that we are behind this process. Now, when Dr. Blumenthal and Dr. Garth Graham said, we know we need help, they asked the collaborative to also look at why providers in underserved communities, the rate of adoption was lower than the general provider community. And so we actually went out into 3 communities in 2010 and 1 in 2011 and did some research and actually came up with an education and outreach program called High Touch. One of the first things we found out is that providers didn't know and still do not know about EHR adoption, about meaningful use, about the benefits. Why do we need to do this? They still do not know to the extent that they need to. And the reason we need to do this is real simple. This is a matter of survival. Yes, if you get an EHR, it will help you improve care coordination, your billing will improve, but it's a matter of survival. Because if we do not adopt, what's going to happen is that we will be left behind. At the same time that we're going through this process of EHR adoption, government agencies are moving forward with new models of care, medical models of care, such as accountable care organizations and medical homes. We're all excited about it. One of the requirements to be able to participate in those models of care is that you must have a way of electronically transmitting and sharing information. So when you look at the list, we go on cms.gov and you go into meaningful use and you look at all the reasons that you need to do this, even though it's stressful, you need to do it. But you also need to do it because of your ability to survive in the healthcare arena so that you can continue to deliver care. Providers say to me in the bad times, get out of my office because I am going to retire and I don't want to do this and I'm not going to do this. It doesn't matter to me. If you're going to retire and you plan to sell your practice, it will matter unless you plan to give it away. The first question will be asked is, do you have electronic health records from prospective buyers or partners? Because it is a must. I know we're thinking about it, but we need to speed up the thinking and really get active in terms of looking at the resources that are available to be able to do this. High touch is really bottom line. We work with regional extension centers, we work with the community, we identify a community, we go into community, we do what's called an environmental scan, which means that we take into account issues relating to that specific community as it relates to healthcare. The medical model that has been used in that community, the leaders of that community, the expectations. Because what that tells us is what kind of education and outreach we need to do to be effective in that community. Doing webinars is a wonderful thing. I do them also. But what we're finding is that really, in our communities, and with the challenges that our providers meet on a daily basis, the most effective way to educate and inform those providers is by touching them. I am Latina. I have been to dances. I have been to golf courses. I have been to shopping centers. I've been shopping with physicians because that's the only time I had to speak to those physicians. And that's what needs to be done. You can get them in large meetings and, give them the meal, but that's just the beginning. You have to touch them. So in 2010, we went into 3 communities: California, Florida, and Georgia. And we applied the high touch. We did our research, we did the environmental scans. We get to know that community to the point that we figure out what's the most effective way to communicate with those providers. And it could be, we developed a call system, the first call system that we had in those different organizations. That was very successful, and so they asked us to move on to the actual vendor-supported program, which started in 2011. And for the first time, a vendor came to the table and say, I hear you, and I have studied this, and obviously there's a return on investment for my organization, which is, logically why they do this. They love you, they love me, they want quality care, but they're companies, they have investors, and they need to understand what's in it for them. This particular company, Quest Diagnostics, came to the table and said, we studied this, we think that there's a return for investment, and we want to partner with the Office of Minority Health and with the collaborative and donate 75 licenses in the Houston area to providers so that they can adopt EHR. This program started officially in April. We actually won the ground in July and ended on December 31st, 2011. In order to qualify, and I'll tell you why, Houston, in order to qualify for the program, the practice already had to have some form of electronic billing. We knew we had issues with many communities in broadband adoption or lack of access, but that was not really our focus at this time. We wanted communities that already had internet, some form of internet access. The practice should not have had an EHR over the past 6 months prior to this program. It must serve an underserved community, and again, we selected a Latino community, and I'll tell you why, and be a small practice. We were not interested, even though in underserved communities, we were not interested in the large hospital system, because even though they have challenges, our focus was really go to the, for lack of a better expression, the lowest of the lowest in terms of resources, and be able to bring this program to the table. They should be able to qualify to receive meaningful use incentives, and consistent with federal law, the provider had to share 15% of the cost of that software, and the vendor 85%. So the provider ended up paying on an annual basis for the first 2 years $2,000 to get a certified EHR. These are just some of the partners that agreed to work with us on this project. We work with the Regional Extension Center in Houston Golf Course, HIMSS Latino Community, the Office of Minority Health, and of course, Medic Success, which is one of our partners, and Quest Diagnostics. Why the Latino community? A lot of numbers, Houston, Texas, has the second largest Latino community in the country. And Houston, 50% of the population is Latino. And we have a growing rate of, in terms of the Latino community. And so statistically, it made sense because it allowed us to go into a community and quickly focus on a large number of providers to be able to implement this program. But there's another reality. when I talk about return on investment. And that reality was that the vendor said, this is a community that we would like to penetrate. We would like to expand our market in that community. That's where our return on investment comes in. And so if we can come up with criteria that meet the underserved requirements and benefit us, that's where the partnership comes in, then we do business. So we selected Houston. In addition to that, we had a lot of support from the mayor of Houston and from stakeholders in the Houston community, because the collaborative already had built a network in that community. These are just some of the facts that I mentioned. We actually used the MUA standard for medically underserved communities that is defined by HHS. So we wanted to be real specific and consistent in how we identify underserved communities, and also we used zip codes to be able to identify those communities. This particular slide, because I really want to get to the findings and the recommendations. This particular slide actually, again, talk about the high-touch process. And, we identify focus community. In this case, it was Houston. Last year, we did it in 3 states. And that was not just limited to the Latino community. That was all underserved. And our engagement strategies are numerous, which I mentioned, including the call center and access to partners. Very, very important. Local partners. The first time I did this, I was in California. And I was very excited about this thing that I had created, High Touch. And so we had this teaching, major conference. And I thought that it would be really nice if I could get all the big folks that I knew out of Washington, D.C. to come to California to this conference and present. These people out here want to hear from those people over there. And I was lucky enough that I had included a local group from the area to help me plan this conference. And they were so gracious. They didn't want to tell me, but they finally said, we don't think this is going to work. Why? Because we're not really crazy about the government. On top of that, we don't think that they know enough about us to tell us anything. So if this is going to work, you're going to have to go to the local community, find experts, which, by the way, do exist in local communities, and put this conference together. So it's very important when you're doing this, and it's very important for you to understand that this is not a Washington, D.C. Issue. This is a local issue. And so we did. We found the experts in those communities. We found the supporters. We found the detractors in those communities. Physicians that really, came up and said, you all are out of your mind. You're wasting your time. I don't see why we're doing this, and this is why I don't think this is important. Because you have to get a feel for the community to be able to help the community. Now, this is the problem, and this is the opportunity. The programs in 2010 were successful, and the one in Houston, they were successful because, from our standards, meaning the collaborative, we were asked to go out, educate, inform, engage, and find providers that were prepared to adopt EHR. And we did that. And I think there's another slide coming. You will see that in the 3 states last year, we were able to contact over 3,000 providers and surveyed 800, and we referred to the REC 200 providers. 200 providers that said, I'm willing, I'm able, my staff is ready, let's go, let's do this. And we were so excited. And in Houston, same thing happened. We were asked to provide 75. I believe we did over 300 providers. We were very excited. We met our goal. How many adopted? Our program ended December 31st. And the actual adoption in terms of the vendor moving forward and getting the provider online was not 75. As a matter of fact, they're still working on it. So our excitement as an organization that we had created this educational program that was able to motivate providers was missing something. And that's what we have to keep in mind when we talk to physicians and their practice, and we talk about what they should be doing and how they can do it. Since we started this program, in terms of results of this pilot in Houston, other vendors have come to the table and said, I figured out and I want to participate. AHIMA has a program currently. AT&T also has a program. MDON also has a program in different states because they see the benefit of it. Program somewhat similar to ours, but the reality is that is lacking something that is holding us back. So when we sat down, our team sat down and spoke with the vendor in terms of, how we did all this work. We handed these providers over to you. And not only the provider, but the staff, which is another key in providers adopting EHR. What we realize is, and I don't know why it's not there because it's here, but it's on this one. I'm not sure what happened there. What we learned was that we need to understand the needs of the local community and the political dynamics. Very, very important. Simple things like when we went to Houston, as I said, I'm Latina. And so I walk into physician offices and, it's different when they realize that you're a Latina. However, they had a major issue with me because I call and refer to them as Latinos. Where in Houston, they wanted to be known as Hispanos, the Hispanic. And so you sit and you go, what's the big deal? I mean, one of them, it makes a difference. That's what that environmental scan should take into account. Learn that community and learn what provider you're dealing with and what's important to those providers. We talk about early engagement of collaborative relationship with physician leaders. Very important to have a network that can support you, teach you, encourage you, and actually help you do the work. Providers, doctors have this thing where they really like and respect the knowledge of other doctors. And so even though I have a lot in my head as relates to the specific of meaningful use and what it means, you need to come up with a strategy depending on who you're speaking to, another provider, to make sure that you have a provider that is respected in that community to be able to deliver that message. So little nuances like that, and some of these findings apply to also the general provider community at large. But for us, we found that it really made a difference if we paid attention to our lessons learned. Close collaboration with Quest Diagnostic. One of the important things is we thought that because they wanted to do this, that everything was okay. But what we realized is that it's not just important that they do their thing and we do our thing, but that we have to do it together. A lot of meetings, a lot of discussions, a lot of disagreements, lots of agreements. And the good news in this particular case is that Quest really wanted to make this work. So it's not just a matter of finding a vendor that says, I want to sell EHR and I want to come into your community and identify those doctors, give me a list and let me go and do what I do best. But it's really finding organizations that are committed to that community. There's a return on investment. They also really need to be a sincere commitment to work with our communities and our providers. Long-term commitment to the process. This was the bottom line. And this is what the collaborative and its partners still think that is missing in this process. So when providers are attempting to adopt, those of you that are here and saying, I'm going to do this, and I'm going to work with the Regional Extension Center. I'm going to work with my friend. I'm going to call the National Collaborative and see how I get this done. What we realized is that that was just the beginning. The education and outreach was just the beginning. We need to have somehow of providing a continuum support to providers as they go through that process. And I'm not talking about continued support in terms of, sending emails saying, how you doing, Joe? That's part of it. But really be able to give additional resources to those providers to be able to get this done. That's what was missing from the Houston project. We came, we worked, we educated, we delivered, and then we left. And we said, provider, vendor, you guys work it out. The vendor tried to work it out, but what we found out is that in our communities, the challenge is astronomical for a provider on a daily basis to do what they do, provide care, deal with the staff, deal with compliance issues, deal with quality reporting, deal with the bad weather, deal with everything and anything that others have to deal with in their environment, which is different, and then talk about, now I am going to talk to a vendor for 2 hours and do workflow analysis and get this thing started. No. They want to, they scheduled a meeting with the vendor, and the vendor's walking in the door and can't talk to you, Joe. Have an emergency. What's your emergency? The bank just called. I'm trying to see what I'm doing with my payroll on Friday. That is reality. That's what we're trying to figure out now. How can we lend a hand? How can we support providers? If there's nothing else for them to pick up the phone and say, Marcy, I missed that meeting and I really need to get this done. Can you talk to the vendor for me and see if I can schedule something? Any and every type of support is welcome and is needed, because that's where we're missing the boat. Our recommendations. We need to identify community stakeholders and create regional consortiums. The reason I say that is because I get a lot of calls from other organizations and other providers that say, we want to do what you do or your organization is doing, and or we need help. But the reality is that what needs to happen is that we have to have an organized method of delivering that help. The collaborative, and not only the collaborative, other organizations, even the federal government have a very large network nationally, but it's not organized from the perspective of coming up with a body that can assess in that particular region what's needed. Can we develop a volunteer service to do this? Can we work with even small businesses within that community that is willing to support those providers, because they understand that if the provider adopts, I can get business out of this. I can come back and be maybe a part-time consultant to their offices because they can't afford full-time. I can come back and help them, deal with developing marketing strategies now that they have an EHR. The small businesses in those communities understand that. And we work with them all the time that are saying, I'll give you in kind, but I'm hoping to get something from this. But that's not an organized system that exists, and it needs to be organized. Holding monthly meetings to continue to educate providers as it relates to meaningful use and the incentive program. It doesn't have to be webinars, but holding meetings and continue to provide that information, because what has happened is that now we're moving into stage 2 of meaningful use. And for the most part, we're focusing on stage 2. So the webinars that you see today and the information system that is out there today is not really focusing on the whole incentive program EHR adoption. Things are moving and we're here. And so we feel that there still needs to be that continuing education offered to providers in our community starting from the beginning. Because the assumption is that because the federal government is moving in stage 2, that we all are in stage 2. We have not even started. Identify and highlight successes monthly. We say monthly. It could be weekly, bi-monthly, and by that I mean all is not dark and all is not gloom. We have providers in underserved communities that are doing an excellent job as it relates to adoption, implementation, and use of EHR. They're really out there, but we don't know about them. We need to, because it really makes it somewhat palatable if you can look at something that you need to do that is difficult and realize that your brother and your sister have done it, and that if you really, really stick to it, you can do it as well. So, you know, this is not Never Never Land. This is a process that requires support from all of us, including the providers, and for us to see that there is a tomorrow, that this does work. Create a repository of local community vendors, and we're working on that. And these are vendors that have come to the table and say, you know, we want to participate. We want to do this. So if someone in X state calls and say, you know, we have a group, a church, providers that are part of XYZ religious organization, and they've decided they want to do this, is there any vendor that would be interested in us that we can make that referral to them? And also, we're in the process also of putting this together, but when we do, we'll be encouraging all to join the NHIT EHR Adoption Consortium. And what we will be doing is, again, putting together resources that are available to those providers in different communities. The small businesses that I spoke of, the advocate that I spoke of, the stakeholders that I spoke of, putting it all together, but doing it at a national level. Now, we believe that that would be successful in terms of being able to provide resources to providers to help them adopt EHR. And the reason we believe so is because we have done it on a smaller scale and it has worked. And so we believe that if we can expand this and do it at a national level, that would lend support to the federal government, to the RECs that are still trying to provide that support to be able to get this done. Because again, the key is to adopt EHR, but to do it at a rate that is going to make a difference. And right now, our rate is not where it needs to be. That's the end of my presentation. When it comes to specifics in terms of why you should adopt, as I said, CMS.gov meaningful use will give you all the specific efficiency, effectiveness, and all that is true, quality, reduce cost, care management, safety issues, e-prescribing medication, safety, all that is true. But the main reason if we don't adopt, we will be left behind. We can't afford that to happen. Thank you.
Yeah, but I think it's really cool about the peer support. That really does make a difference, is taking providers that do face those same challenges every day and say, look, this is how we did it in our center. We face the same challenges that you do, and let me help you. We're here. Just call us. I know that would, really work with us. So I'll give you a card. Well, now we're on to our next speaker. Everybody awake? Okay. Dr. William P. Sawyer is an innovator way ahead of his time. He has become an international expert in hand awareness. Through 4 principles of hand awareness, he has created a multi-sensory primary infection prevention program that once viewed is never forgotten. During his 26 years of practicing family medicine, he has perfected these behavior modification techniques and training strategy throughout his patient population. So we're here to welcome Dr. William P. Sawyer.
No, I don't need that. Yep, thank you very much. Hey, good morning. How is everyone? Great. Well, I'm feeling, after I've heard Kathleen's and Marcy's discussion, feeling a little doom and gloom at times, and I want you to touch me so I feel better. But I'm a solo practice family physician for 26 years, and as they're telling me what I have to do, I'm happy to hear you say, it is tough every day, and now you're asking me to do more? And very funny, I would share with all of you, it's a right strategy to complete. It's a process, and how do we do it? And many docs in Cincinnati, a bunch of us say, who are in private practice, say, show me the money. I hate to say that, but that's part of it, because we can't work harder, hire more staff for less. So we're together, we can make a difference, so let's just hang together here. So a little bit of housekeeping first. So some of you have on your table a little plastic container that you're wondering what that is. So if somebody can sort of identify it and take a hand of it, it's a little clicker. So I'll tell you a little bit about this. So you can't click it yet. I mean, so you're thinking about it. We'll get to the end. So let's see how we do. So I'd like to say thank you to Dr. Webb for inviting me to talk here, because when she contacted me, I thought, okay, National Public Housing Conference, okay, a family doc, and I do family and solo practice, family. And as I looked into it more, I thought, God, this is a perfect marriage, so to speak. Not she and I, but the conference. So there's, because it blends everything together. It's where take care of the patients where they are, not where they should be, down the street, 10 miles away, in my office perhaps, but at school, at the site, at the center, at the housing center. Let's do this. So that's a big picture. So thank you, Dr. Webb, for inviting me, and others have asked me why. So what I would hope for all of you to take home today is a life-changing behavior that will enable you to never again contract a respiratory infection. Flu-like illness. Can you imagine that? Does anybody believe that? Who doesn't believe that? I'm going to ask you to, okay, good. Oh, there's a few doubters. We always like that. It's true. I'll tell you it's true. So stick with us. So your question also is, how does a solo practice family physician in Cincinnati become an international expert in infection prevention? You hear about infectious disease, ID docs, ID as a process and a discipline. But what's this infection prevention? It's a strategy to keep you well and stay well. So what it does, it starts with somebody who has allergies, asthma, went and spent time in the hospital when he was younger, becomes a solo doc, and has children. And his wife is his office manager. And then when we had each of our children, they would come to the office for the first year and sleep in a box. And when they got up and they were pulling the charts out, we had to ship them off to daycare. And I was convinced they were not going to fall into the cesspool of disease and come home sick and go to the hospital. So I thought, we have to do it different. So I gave the center 4 packets of baby wipes. And I said, please wipe every infant's hand in the area 4 times a day, just randomly. My God, anecdotally, they were healthier. The kids in their area were healthier. And so as time went on, we, in the mid-90s, created a curriculum and built a costume and went to schools. My gosh, and the kids years ago, and my son is now 24, and they remember this. And I thought, gee, this is something that's tremendous. We need to keep this going. So what we did was, in 1999, in Cincinnati, there's a health improvement collaborative, in the first flu vaccine shortage. And they go, what are we going to do? And so Malcolm Adcock, the health commissioner there, says, oh my God, we need to do hand washing. So we said, all right, let's create the first national hand washing awareness week. It's the first week of December every year, so everybody pay attention. And we had a program and coloring posters and all, and he was washing his hands in the bathroom, and there was Henry doing it with him, and it was a great success. The next year, there's more than enough vaccine, and they said, well, maybe we don't do this. I said, no, you have to keep going. This was really successful, so we've kept it going. And then ever since then, we've tried. I created a foundation in 2009. It took me a couple of years. I thought, this is the right program. And everybody needs to do this. Somebody needs to take this to the world. And so we've sort of gone back and forth with who's going to lend a hand and carry this. So, and it's not about hand washing. This is the piece that became very obvious. It's not just hand washing, because that's one single event. It's also about cross-contamination. Food service has taught us about this, and in healthcare we need to do better. So it's around hand awareness. So hand awareness is knowing where your hands are and what they're doing at all times. Okay? Scientifically, it's hand hygiene, respiratory etiquette, and cross-contamination awareness. So during our program early in the 90s, we created the 4 principles of hand awareness, which are wash your hands before you eat and when they're dirty. 2 is do not cough or sneeze into your hands, throw an elbow. And 4th is never put your fingers in your eyes, nose, and mouth. It's the only portal of entry into the human body for all infectious disease, respiratory and GI. Imagine that. Now, who's heard that? Who has been told that repetitively? The mucous membranes of your eyes, nose, and mouth are the only portal of entry into the human body for all respiratory infections and GI, right? Nobody. Oh, one person. Okay, great. Hey, somebody's heard about it. Fantastic. So we want you all to spread the word, not the germs, about this. So why is your question? Why do we do this? Because we are the petri dish that grow all seasonal illnesses and infections and pandemics. Imagine this. If we never grow these organisms, cook the pig, we'll be fine. There'll be no more pandemic if we do this. So cook the pig, cook the bird, it's okay. So what we saw back in 2009, when there's the pandemic fear, my gosh, there's no vaccine, it's going to happen, where everybody's talking about millions of people are going to die, this is going to happen. But what happened? They were promoting hand washing, hand hygiene, hand sanitation, respiratory etiquette, do this. And they did say avoid touching your eyes, nose, and mouth. But they didn't say do not put your fingers in your eyes, nose, and mouth. And what happened? Hardly any schools closed down that year. Incredible. But what did happen? All the grocery stores, you couldn't keep sanitizers, wipes, paper towels, and soap on the shelf. But they had tons of cough and cold medication. They couldn't sell it. People were healthier. My gosh, it worked. This promotion of this true primary infection prevention strategy worked. So what happens? The next year we have plenty of vaccine. Pandemic risk is over. There's hardly any promotion. So what are we doing? It's the right thing to do. Hospital-acquired infections. Oh my gosh. Who's been to the hospital recently to visit somebody or stay? No? Anyone? What's happening there? We doctors and nurses are spreading disease around. C. diff. It's ravaging the hospital. MRSA. So what are we doing? We've got the tools. We're just not doing it. So what we have to do is do something different. It's called positive deviance. Now, many of us when we were younger, if you were called that, you were isolated and put aside and nobody wanted to be around you. So positive deviance today is a great thing in healthcare. That's what we're trying to do, is change the behavior. So positive deviance is act your way into a new way of thinking instead of think your way into a new way of acting. So there are, based on these 4 principles of hand awareness, we have some tools. So the first one, wash your hands before you eat and when they're dirty. So we have a nail brush. It's the forgotten tool. It's not only for the ICU and the newborn unit. It used to be around 60 years ago. We've forgotten it. What's under these nails? So we say, pass this on. The sniff test. For kids, we know what that is after washing. For college kids, it means something else. So we don't. That's the college program. 2 and 3, respiratory etiquette. We want you to know when you cough and sneeze. What happens when you cough? Gee, oh my God, there are droplets that come out. You go around. It's amazing. Who knows that? Who coughs in their hands? Why would you do that? You're going to go shake somebody's hands and pass it on. Number 4 is cross-contamination awareness. How do you stop that? How do we do this? Because look at the germs that are on your hand. You have a black line. You've seen these things. You can't see them. So it's a very hard habit to break. We can't handcuff you, but we have a training device that you can use, which is called the barrier method. We use barrier methods for other parts too, but this one's different. This is for this head up here. So what we want you to do is to learn how many times you touch your T-zone. T-zone, did I say T-zone? What's the T-zone? Oh, there we go, exactly. We said T-zone, it's the mucous membranes of your eyes, nose, and mouth. That visual aid, so we're watching. So that brings me to this clicker. So when you see some of your peers, presenters, and others today touch their T-zone, we want you to click it. And my wife will say don't say this, but I'm going to say it. Click it, don't lick it. So now, when this happens, people will start looking around and go, what happened? And they'll say, you are going to spread the pandemic, cause the pandemic over there. So please don't do that, because together we can make a difference. So it's the accountability that's so critical for all of us. Again, in the hospital, it's the same thing. I mean, I'm waiting for them to shackle me, and then when I go into the room, they're going to say, all right, open up, take it off. This is before you touch the patient. All right. So I brought a special guest with me today to sort of help you take this message home. So we're going to count to 5 maybe. 4. Henry, is anybody coming out here? Hey, I don't know. 2. Hey, talk to the hand. Hey, exactly. So Henry is happy to visit all of your sites. He's a tremendous messenger and ambassador. So what we do is it'll change everybody's behavior, because if we don't change your behavior and you don't change it, you can't help anybody else. So thank you very much for helping to spread the word, not the germs. Exactly. All right, thank you, Henry. I know.
Thank you so much, Dr. Sawyer. I think that woke us all up, didn't it? That's great. Thank you. Our next speaker is Ms. Fredette West. She's a steadfast leader in health policy and health advocacy. She's the chair of the Racial and Ethnic Health Disparities Coalition and director of the African American Health Alliance, both of which are committed to eliminating racial and ethnic disparities in health and healthcare and improving access to quality healthcare for all. Together, under Fredette West's direction, REHDC and AAHA, which is, oh, wait a minute, we got it. It is the Racial and Ethnic Health Disparities Coalition and the African American Health Alliance. You got it? Good. So together, they are leading advocacy organizations in advancing minority health improvements and health reform. To that end, the Affordable Care Act law includes in some form all of the health reform provisions championed by the African American Health Alliance and Racial and Ethnic Health Disparities Coalition. Fredette West has remained at the center of countless health policy battles and accomplishments. Here we have on April 24th, 2012, Fredette was awarded the Lifetime Achievement and Health Equity Award for outstanding efforts to improve access to health care for emerging populations, awarded by the Congressional Black Caucus Health Brain Trust and National Minority Quality Forum. So we're proud to welcome Ms. Fredette West.
Good morning, and thank you all for being here, because you all could be somewhere else. And thanking God for having allowed us to come together again, because He didn't have to breathe into any one of us this morning, and He did, and still is. And some that were alive this morning, already gone, and some more will even be gone tomorrow. So we need to talk about and move in the urgency of now. It's always good to see the Public Health Service represented. And I'm going to ask everybody to take a moment to stand and stretch, because you've been seated for a while. Public Health Service too. Okay. And let's take I see one stretcher, 2, 3, 4. That even makes me feel good. So I will too. I will too. Thank you, dear Lord, for allowing us to be here, to be able to stand and stretch to whatever extent we can, because we don't even have to be able to do that. And pleased to see the hand that came through, so if you'd have a seat, please. But look at how much power we have when we all move together. You all don't know me, yet you stood for me and you stretched. That you have lent me your trust through Dr. Webb and others. What I'm going to talk to you a little bit about today is community organizing and how important that is. Notice how some got up, some didn't. Then when I said, okay, let's all of us get up, then more got up. That's all that community organizing is about. Look at the hand that was just presented to you. What did that hand really do? It stood up. It stood up. And you'll remember it because it stood up. Had the doctor just walked away, left this conference without that hand, you're going to remember that hand. Had that air not gone up in it, and it had remained silent, you wouldn't remember that hand. You'd just know that doctor had a click. But a click for what? What did it do? But that hand reminds you to wash your hands and how important that is. So again, I want to talk to you a little bit about community organizing and the urgency of now. Not just because it's an election year, but period. That hand, and each of you when you stood up, I didn't ask any of you if you were Democrat, Republican, or Independent. But you stood up collectively. And that's all it takes within community organizing, is for all of us to work together. Realize the power that each and every one of you have at your fingertips that really goes unused. Silence and fear will take us out of here. Not too far from here, just metro stops away. You're looking at a Congress that is in recess. Recess from what? What have they been doing but gutting programs right and left? How much can that take? But they can only do that gutting because it's no longer cutting. Cut's gone. It's gutting now. When you look at an office like the Office of Minority Health, whose budget is $55 million and a proposed cut of cutting $15 million, who's going to stand up for that if we don't? And people that benefit from that office. Who's going to stand up for those that fund Dr. Webb's programs and all the others? I see you have on the agenda Congressman Danny Davis, and thinking about all that he has done in community health centers. Community health centers are a big winner in health reform, but they won't just stay there if we don't stand up for them. Silence and fear does kill. I know we're working on an executive order. I won't go into the details of that, person called me who is a colleague from years back and said to me that, well, Fredette, I don't have a fight with you because I don't have any bone in this fight for this executive order. And I thought about it, and I said, no, I don't either. I said, my children are grown. And then I thought about it further. I said, oh, yes, you do. You're still on this earth, so you got a bone in this fight. Because this executive order is about children. So it doesn't matter if your children are yet to be born, if they are young children or old children. You got a bone in this fight. And you all have a stake in the fight that's just a few metro stops from here. But those cuts in community services block grants will go away forever if you remain silent. And when budgets are gutted or cut it to the extent that they're bare bones or can no longer carry out their policies effectively, people should be in an uproar. We're talking about quality of life programs. Medicare, Medicaid would be nothing like they currently are. Totally rearranged in such a way that they would only carry their titles. We got to mean more to each other than just that. So silence does kill, fear does kill, and I don't know how much time I have left because you told me the time was tight.
Yes.
So I don't know how tight it is. Is it up?
No.
Is your time up?
About 5 minutes. 5 minutes.
Okay, in my 5 minutes, mind you, they gave them to me. I want to share them with you. Tell me if you can, and if you are committed, what will you do when you leave here? Because there's no point, and I'm not trying to mess up your program, but there's no point in being here if you're not going to go back and do something. Otherwise, you just came and sat and had in-house leave. And in-house leave is too expensive. I don't want to say GSA, but in-house leave is too expensive, way too expensive. So what is it you're going to do when you leave here? And I heard Marcia talk about ONC. Look at the billions of dollars ONC got. Come on, give me a break. Hold them accountable. You can't expect docs to do overnight with a few dimes and a few quarters. Hold them accountable. Hold the agencies accountable. Monitor what they do. You're paying taxes. And honestly, you need to pay more taxes. All of us do. We can't keep these programs don't run off air. Revenues are what run our government. Government is not bad. Government is good. Look at the people who were once poor. Somebody depended on some form of government service to help get them over. And now we're talking about do away with all of it. And we're talking about new poor. Again, give me a break and give people a break. Let people keep their dignity, at least their dignity intact. We're at the end of the month, beginning of a new month. New unemployment figures will come out. We can guess where there will be double-digit unemployment still. Again, give people a break. Help them help somebody. But again, my minute's going to be gone. At least 3 people tell me what you're going to do when you go home. I don't care what 3, somebody stand up. Thank you.
The first thing that I'm going to do is I'm going to go to the local health centers to find out if they're utilizing the electronic record system and to see why or why not they're not using it. I'm also going to the Hill tomorrow to talk to some of the assistants about the healthcare and the importance of healthcare for public housing residents. I work with public housing residents 24/7 implementing programs to help public housing residents. So I'm bringing this information back to them as well.
Great. I need 2 more. Somebody stand up. You already stood and stretched. 1.
We're going to create more jobs for people within the community that we serve. We can do it. We just put effort and focus on that.
Stand, please.
I'm going to go back.
Can you yell it out?
Yes, I'm going to go back to Philadelphia and convene a meeting of my partners who are in the healthcare field and our staff who are frontline staff with people who have health issues and talk about what was learned from this conference, my colleagues and I.
Good. Very good.
Come up with some low-cost, quick-to-implement ideas that
Very good. And notice that the backdrop against all of this are continued threats to dismantling the Affordable Care Act law. And when you say Affordable Care Act, go on and add law to the phrase, because there's still too many people that don't realize that it is the law and that you have rights under that law. And if for any reason that law is repealed, don't expect anybody else to lay their political lifeline blood on the table to try to get it again. So if we lose it, it's because we gave it away. Thank you so very much. Please keep me and my family in your prayers, and we'll do the same. And thanks again. The same for you.
Thank you so much for that. I think definitely we all are advocates in our community, and here we have the opportunity to go and advocate here in DC for the rights of our populations and the right of health care, and we have to take this opportunity and go for it tomorrow. Okay? Great. Thank you so much.
Thank you. Thank you very much to all of our panelists. Didn't they do a tremendous job sharing some information today? Thank you so much. And I would like to thank Zara. She did a phenomenal job moderating, so thank you again. So I know, I'm sorry? Miss Fredette West. And we will have all the information revised, everything uploaded on our website, so you can also have access as well. So we know we ran a little into your break, but I think this was really, really important for you to hear, and it was worth waiting for the few minutes. So we're going to break now, and then try and get to your workshops as soon as you can. We have a lot more for you to enjoy for the rest of the day. So thank you again, everyone.